Welcome to Speech Scope, a MedBridge podcast where we conquer challenging topics for the medical SLP. Our aim is to deliver actionable takeaways for clinicians like you through captivating discussions with experts in our field. To receive continuing education credit for this episode and access bonus resources, make sure to check out medbridge.com. Hello, I'm your host, Sarah Baar, a clinical SLP in Michigan with over 15 years of experience. I specialize in adult neurogenic disorders and the life participation approach. Today, I'm excited to be joined by Lauren Schwabish, a seasoned and passionate specialist in person-centered care for adults with acquired brain injury. Today, we get to focus our conversation on one aspect of brain injury treatment, and that is working memory. We'll be diving deeper into this topic, including recent research and actionable takeaways you can implement right away. Welcome, Lauren. Can you get us started by sharing a little bit more about yourself?
Thank you for having me, Sarah. It's so nice to chat with you today. So my name is Lauren Schwabish. I have been a speech language pathologist for 24 years. And 21 of those were spent in acute care and acute rehabilitation hospitals in major metropolitan cities. I just got a ton of experience in a lot of different medical settings. So trach and vent, rehab, long-term care. The hospitals I were in diverse cultural, socioeconomic populations in New York City and DC. So that's sort of been my background. I've always really loved learning about the brain and what types of clinical syndromes happen with different types of injuries. So, why does someone with anoxia look different than someone with, let's say, a right CVA? Really differentiating in those ways. And my last job was really focused more on acute neuro rehab. And I was so lucky to have the most supportive director and mentor really help me become a very strong clinician. With a lot of opportunity to learn and grow my skills. Eventually, I became a rehabilitation clinical specialist there, and I was in a position to help new clinicians really elevate their skill set, not just clinically, but professionally. And I was able to create curriculum related to learning about the brain with a really special focus on stroke. I developed a stroke education class for patients and families, which was a great way for empowerment. So those populations could, leave our hospital and know how to take care of themselves. So they would continue their recovery, and did a lot of community outreach, and I loved it. And then the pandemic happened, and I switched it up, and I started my own private practice, and that was in 2021. And very quickly, I had to upskill and learn a whole new set of skills about working with people with cognitive communication impairments in the community. And I watched a lot of MedBridge webinars to really help myself understand what, milder impairments look like, or just sort of a different clinical population than I had been used to. And so now I deliver very niche therapeutic services in the home and in the community. I really focus on promoting self-advocacy and confidence for patients with aphasia, acquired brain injury, and mild cognitive impairment. And I had to learn how to run a business. But I am so gratified and satisfied with my career. And I've been able to participate in a lot of ongoing clinical education like this. So that's been good too, to hold on to that.
Wow. So it sounds like, one, you've never been bored. You've done so many things. I love just hearing your story. It reminds me of my story, kind of seeing a lot of the big rehab hospital stuff, and then moving into private practice where you get to really hone a little bit of a different set of skill and make things super personal for clients. And I know I love following you on neurospeech services, and I think you have such a talent for educating clients and SLPs. So I'm really excited to dive into our chat today, which is not just about brain injury treatment in general, but really how to address the kind of niche of working memory impairments. So as we get into this, let's just kind of set the stage and get on the same page. What are we talking about when we use the term working memory? And then what are some of the challenges or critical thinking questions we need to be thinking about with that topic?
Yeah, so I think just like, sometimes we'll go to like a cocktail party and you say you're a speech therapist and no one really knows what that means and you have to do a lot of explanation. I think working memory is the same, right?
Oh,
So,
yes.
right? Like a lot of people say like my memory very generically, or they know about long-term memory and they know about short-term memory, but almost nobody sort of everyday lay person knows what working memory is. So, and that includes our patients and their families. So I think there's a lot of education that has to come along with this. So the clinical definition of working memory is that it is a limited capacity system that allows for the temporary storage, manipulation, and maintenance of information in performing a complex cognitive task. And that's the big piece here, right? And we'll get more into that. It is different from short term memory, which is really that passive holding of information. So I like to think of working memory as a very dynamic process. And there's two types of working memory. You have verbal working memory, and then we have nonverbal or visual spatial working memory. So different types of information are coming into that space. And working memory is also really closely intertwined with attention. So one of the things we'll talk about is like, how do you differentiate all of this? I think that's the hard part for a clinician.
Right.
But the really tricky part, and Sarah, I know you can identify with this, is that in a speech therapy context, so many of our tests and assessments and workbooks are decontextualized and they have almost no connection to functional life, right? So I was thinking even this morning about some of those sessions I spent back in the hospital asking a patient to, alphabetize words or sort them based on size. And like, that has nothing to do with their everyday life. And I'm really happy that I have that perspective now. So assessments that look at, digit span, spelling words backwards, and back tasks, the Stroop task. These are all things we would recognize, and they certainly do help us to understand, the mental manipulation demands. So like you can really understand what it means to hold information in your head when someone gives you 3 words and tells you to sort them by feature. But once you establish a client's performance on these tasks, how do you translate that to everyday life, right?
Right. Yeah, and
Um,
that's so interesting because that when I was in inpatient rehab, that was like definitely what we did is like, oh, you can't alphabetize this 5-word sentence. So that's what, then I'm going to do that exact same thing in therapy and like never like bridged out of like, okay, like that, what is that telling me and how does that apply to real life? So, yep, we do the same thing here.
yeah. So I think what really helps is to think about looking at everyday tasks and then learning to see where the working memory demands are in those activities. And that's sort of almost like working backwards, right? So instead of starting with, counting backwards or spelling world backwards, looking at a functional task and then saying, well, what amount of information is this person having to manipulate in their brain while they're executing it? So just some like examples off the top of our heads here, right? Dialing a number you just looked up, getting the right amount of baking soda out, after you consulted with the recipe, following directions, any type of mental math, keeping track of what someone is saying to you in a conversation, controlled searching of your long-term memory. So like searching for the name of your, high school English teacher, you've got to be able to hold that in your mind while you're sort of cycling through the archive. Navigating multiple tabs on a desktop computer, or my favorite, entering the 6-digit two-factor authentication code I get on my phone when I'm trying to log into my EMR, right? I mean, that's a long series. That's a great example of like functional digit span, right? But it's in a task where I'm trying to, get into my EMR.
Right.
And one of the things for us working in the aphasia space is exploring AAC, right? So a high-tech device or a low-tech device, especially those higher tech ones, think about how many layers of information someone has to scroll through in order to find, the information they're looking for, right? So those are the tasks we want to really start looking at and inquiring about and seeing the working memory demands of the, in those situations.
Oh, yes. I'm already excited just because we're starting our conversation with like the in context tasks, and there might be people listening who really have never thought of it that way before, right? Like when we're we're doing the alphabetizing, like what does that actually mean for real life? So let's take a moment to just talk about the recent research that's important to cover. Can you share some important takeaways? Like what's research telling us about working memory at this point?
Yeah, so this is really interesting. There's a lot of sort of like neuroscience and neuroimaging. So when you go into the research of working memory, there's a lot of like computerized models, and they're really trying to figure out exactly where in the brain things are happening. And sort of the classic view was that there was sustained activity of neurons in the prefrontal cortex that are responsible for working memory. But I almost think of it the way we used to think that like Broca's and Wernicke's were just a single region where things were happening. It's really more about the networks.
Yeah.
And as you look into like, again, science, it's like way over my head for sure. They're talking about like spikes and, different types of chemical signals. So it gets really complicated. But essentially the prefrontal cortex is kind of the main player, and as well as the inferior and middle temporal lobes and zones close to the intraparietal cortex. And of course, we know these regions well because these are typically the ones that are getting impaired in a stroke, that are very focal to our area of specialty. So it's nice to know, obviously, that that's a part of the brain that we want to learn more about. But when I look at the research, one of the models that kept coming up was this model by these two experimental psychologists named Badley and Hitch, and it was called the multi-component model. And this really helped me to understand how working memory operates. So Badley's model basically described two storage systems for incoming sensory information. That was a phonological loop for auditory information and a visual spatial sketch pad for visual information.
Ooh.
And then there's a third part, which is a central executive responsible for processing and manipulating that information. So the central executive integrates information from the phonological loop and or that visual spatial sketchpad and connects short-term memory to long-term memory. And this is really key, the central executive also for these higher demand tasks, when maybe the demand of the incoming stimuli exceeds the capacity. Because remember, working memory is not infinite. It has a limited capacity. And so then we have to selectively attend to information in order to regulate it. So I think about it like if I'm standing at the pharmacist counter and I'm listening to them telling me about a medication I'm picking up and I'm listening to their instructions, my central executive has to turn down the amount of information I'm trying to process from the conversation behind me, because I'm choosing and prioritizing what I need to know, right? So that's a sort of that top-down executive control of that prefrontal cortex. We get to choose what we're storing in our working memory for that purpose, and we get to choose what we're no longer listening to. And so this is why working memory is actually found more in the cognitive domain of executive function, which I think is interesting to think about, in that it's not sort of like another, if I'm thinking about my template, when I'm writing on my evaluation, when I'm in memory, I can comment on working memory, but I oftentimes look at it in the scheme of a larger executive function test.
Just because, are you saying like there could be like, we could almost train people, like you have some control or like metacognitive awareness of like, oh, hey, I got to really pay attention now because the pharmacist is giving me instructions. And that's kind of more of the executive function choice. Is that kind of how you see that?
I think so. I mean, I think working memory can be so quick and fast, right? Like glancing down at something, like my code example earlier, it feels very almost automatic. It's so quick. But yes, as always, metacognitive awareness and teaching someone when maybe they're taking on a little bit too much, or maybe to a family member to say, you know what, I need you to pause for a second while this person handles this direction because we don't want to overload their system. So it is really important to look at, yes, this is about control of your memory, control of information that's coming in.
Great job. I feel like I'm learning already. Okay. So I think we're kind of on the same page. I like that you're encouraging us, like, let's think of this as part of the executive functions because it is more complex than just kind of like what we talk about with short-term memory or even just like those more like basic attention skills, although, attention is needed to do that.
Mm-hmm.
So let's talk about then, let's move this into the clinic, and you have tons of clinical experience. So um, we'll first just talk about the client that is going to be relevant for this discussion. So are there certain severity levels or like prognosis factors we need to take into account as we think about addressing working memory challenges?
Yeah, it's a great question. So I think that the more severely impaired patient, the working memory demands are still there, but who's going to be responsible for those is probably more on the clinician and the people around that individual, right? So that's where we're talking about trying to reduce the amount of ambient stimuli because that person's attention system might be wide open and they're trying to attend to the call bell out in the hallway and the TV and the instructions coming at them. And so it's our job to sort of engineer that environment so they can use their working memory most effectively. It's about sensory inputs, right? So does my client have their glasses on? What's their hearing like? Remember the phonological loop and that visual spatial sketchpad, that's a sensory process. So really optimizing their sensory inputs. Obviously, like you mentioned, looking at attention. So, how are they handling distractions? And because it's metacognitive, you're going to have more probably success in the education of this with, let's say, a less severely impaired patient who can handle that level. But another consideration is really someone's baseline working memory capacity. What I've learned in my private practice life is people living with ADHD actually have very limited working memory. And this is a really worthwhile piece of information. If you're working with someone who maybe has a prognosis or a diagnosis of, let's say, an acquired brain injury, and they have ADHD, those comorbid diagnoses is going to be really significant when you're trying to think about addressing this. And as always, we have to really be asking really thoughtful questions and arranging for observation of meaningful functional activities to really understand what working memory looks like in real world situations.
Yeah. So let's kind of dive into that. So, let's say you're kind of at that assessment time with a client, you're kind of trying to sort out, what the challenges are, or like this is the moment where you're maybe going to get, okay, I need to address working memory on your radar. What are like the types of assessment tasks you're doing where you're starting to think that, or you're getting information about that?
Yeah, so I've really been drinking deep from the cup of patient-reported outcome measures, as I know.
Ooh, I love the cup of patient-reported outcome measures.
And what I love about being in my practice is I get to choose whatever I want to do, right, for assessments. And so I've really selected a way. I will also say a lot of my patients come into me with they've done neuropsych testing and they've done a lot of that digit span and, remembering a short story and decontextualized tasks. And they are so frustrated by it that I actually avoid those whenever possible. And instead, I'm really using patient-reported outcome measures. Two of them that I use a lot that I think are really helpful for working memory is the BRIEF A, the executive function patient-reported outcome measure, and then the MMQ, the multifactorial memory questionnaire.
Awesome. We just quick dive in.
Yes.
And we'll maybe link those in the handout just so if people are listening and driving, they could try to use their working memory and just jot it down in a moment when you're safe. But otherwise, we'll put them in the handout.
Definitely. And actually, both of these are, I believe, free access, which is important. But I think these are really helpful. And what I look for is, and I look for this in their questionnaires, when there's a sense of a loss of the set, right? Like I had a thing in my head and now it's gone, or there's a lot of inefficiencies in completing a task. So they have to constantly go back and refresh, what they were doing. They're losing their place. The train is off the track. Whatever the analogy is that they give you that suggests that information can come in, but it's really unstable. An inefficiency for someone who's working, right? Or someone who's trying to, execute a household task, that's a big deal, right? So items that I tend to pay attention to on these proms would be difficulty remembering a phone number you just looked up, difficulty recalling the name of someone you just met, you just heard their name, forgetting what you were about to do, like walking into a room and forgetting what you went there for, forgetting to relay a message, forgetting what you were about to say in conversation, walking into a store and forgetting to buy what you intended to buy. These are those like everyday occurrences that are so frustrating to people. And, someone might have good attention, good memory, but it's that working memory. If I know when I'm sitting in my car that I need to buy, Triscuits, and I get into the store and I don't remember that, well, look at the, overall stimuli that's coming in, right? So I've changed my environment. There's a lot to pay attention to. I can get easily distracted. Maybe I'm buying other things. So that's the mental manipulation piece here. And so really learning to attend to that type of breakdown for a patient, I think is really important.
Fantastic.
Yeah. And then there's, of course, functional observation. So I sort of really had a mean reputation in the hospital as being someone who was very functional. And that's because that shows you everything you need to know. So, how does an individual manage a conversation or a directive or a question they're being asked, especially when there's other stuff going around? How do they do with switching tasks? If they're going from one thing to the next, how do they handle that? Especially if there's a built-in delay. So working memory has this sort of like, very brief shelf life. And so if I'm working with a client and they have to all of a sudden restart their computer, or they're waiting for someone to return to a room in order to ask them a question, how long is that information hanging out there? So that's another thing. I think that's the real thing here is that clinicians have to get good at observing for these types of breakdowns. And then really
be like not being afraid of like choosing to do that type of task in an assessment and knowing like this is super valid to do contextual observation, and you actually get a ton of meaningful information in an efficient way. But sometimes it feels so different than when you have like a paper and you've done all your pluses and minuses. So I think SLPs avoid that. But you're right. If we're doing the contextual observation, that's going to let us see it so quickly.
Yeah. Especially if, let's say you have a client who's like a super multitasker, and this is a point of pride for a lot of people. They're like, I was a great multitasker. Set them up in a situation where they need to be multitasking and then start a task analysis with them. And it doesn't have to be anything formal. I might predict, have them predict how they think they're going to do. And then we might do the task and then do a post-task analysis, see if they can start to pick up on this. Many people are very aware of these types of mistakes, and it doesn't, once you establish that awareness, then you can start to deal with it. And that's very different from having someone do a Stroop task or, counting 7 digits forwards and backwards. If someone has difficulty with that, it's hard for them to really get buy-in as to why they might want to practice that. But if you say, hey, you know what, you were supposed to, do you remember what the receptionist said to you when she was giving you the date and time of your appointment so you could enter it into your calendar? And they're like, I had it, and then I opened my phone and then I lost it. I mean, that it's not hard to see, right?
Yeah.
Not hard to see. Another thing I will say, Sarah, is anxiety. Whoa. So I see a lot of folks who have anxiety. I think some of these diagnoses, that can be something that's amplified. We know people with stroke are an elevated risk of developing anxiety or depression. Same thing with people with persistent post-concussion symptoms. And anxiety is certainly, I have a research paper I oftentimes will hand to patients who have this issue to say that anxiety and working memory are very tied together. And I always say only one person can be the driver of the car. So if anxiety is at play, we're going to see some working memory issues there too. So that's where, helping people to validate that experience, reinforce the benefits of anxiety management, and tie that back to working memory too.
That makes me think of the movie Inside Out too. I don't know if you saw it, but it's all like the feeling. So anxiety does come in and drives the car every now and then, and it affects other things. So
yeah. I always imagine it like, and I didn't see that movie, but I think of like Animal from the Muppet Show, like crazy, like taking the wheel and just Because it does feel, and I've had patients just tell me this last week. We were talking about judging task complexity, and all of a sudden, my client was like, I'm feeling really anxious, and my whole brain has frozen. Right. So even being able to verbalize that, recognize that, and tie that to working memory that's a big deal.
Big deal. Yep. So as you talk about working memory with your clients here, you and I, we're kind of neuro nerds. We find these like frameworks really cool to talk about and the different loops that control working memory. But then we always have to code switch for our clients and make it understandable to them to help them gain control. So I just would love to hear how you provide education about this cognitive skill.
Oh, yes. This is one of my favorite things. I had a whole bunch of Instagram posts about my favorite analogies. Analogies go so far with translating neuroscience to the everyday person. And so my favorite analogy for cognition is a multi-story building. So think about, you got to take an elevator, it's going up and down, it's got a lot of floors, right? So the foundation of that building is attention, right? If there's cracks in your foundation, all your floors are a little shaky, right? So we've got that foundation, can't really see it, but it really needs to be shored up and strong. And then as we go up to maybe the lobby, we've got processing. People are getting into the elevator, right? So that's where we're talking about your auditory information, your verbal information. And then we start to rise up in the building. Next stop, memory, right? So, when someone's talking about their memory and they're like, yeah, my memory's no good, we have to go down to the first floor in the basement and see, well, how is attention and processing working? And then we think about those higher level skills. So as we rise up in this building, we're stopping at organization and problem solving and reasoning, etc. And I say the penthouse of this building are your executive function skills. They rely on all the other floors, right, in order to function well. And the working memory piece of it is that elevator, right? The elevator is not infinite space. There's only so many people who can fit on there. Some people's elevators are little, some are small, and it's dynamic. So it's taking that information that got into the first floor and it's taking it to the level that it needs to, right? And it's just so helpful. A lot of people will give the analogy of like a mental scratch pad or a mental post-it note, but that really speaks more to like a static, external piece of information, where this elevator analogy, it's like it's constantly moving, it's constantly changing. Nobody lives on the elevator, right? People are getting in and out. And then the analogy really paints a wonderful picture for someone who maybe doesn't think about their thinking.
Yeah. I like that. I've never heard that analogy, first of all, so love it. And it really gets at that network idea where it's not just like, that one place like for short-term memory, but it's like really interacting with a lot of different cognitive domains. And thanks for sharing that.
It is one of my greatest creations. I literally just came up with it. And this is that sort of permission, Sarah. I think honestly you helped to foster in me, whether you know it or not, is that we do what is right for our patients and clients. And as long as we understand the science behind it, we don't have to go with any fixed anything. I don't have to throw research at somebody. If this analogy works well for them, I literally drew it on a whiteboard the other day, and a patient's family member was like, "Oh my God, I never thought about it that way." So it's an effective one.
Cool. I like how that it connects all the parts of cognition, because that's how it is. We're not just like living in little bubbles. So.
Exactly.
So let's talk about then your treatment or your intervention sessions. I would now like to hear, what do you do for, you're like, all right, we've identified a working memory challenge with a client. So what do you actually do in therapy? What does that look like?
Excellent question. So like we were just talking about, I always start with metacognitive education, but I pick a level that the client can handle, right? And so this is where you just want to sort of start with those open-ended questions, non-judgmental, tell me what you know about your brain. Tell me what you've been told so far. So really kind of feeling out where they are, always using a lot of visual supports. I think cognition in particular is something people take for granted until it doesn't work. And so I always like to say everyone benefits from understanding, like a memory 101. to help them delineate the different domains of cognition and then show how we're all, those are all interactive and also how it's connecting to what's going on neurologically. So that's where we can think about, is it due to, let's say, a stroke, or are we dealing with mild cognitive impairment? And my evaluation process now, as I've evolved into private practice, is really about collaborative goal setting. So we're about identifying the meaningful context and then what strategy options will work for them. And I always like to ask clients to define for me what success looks like. And especially in working memory, it is such a dynamic process. We want to identify, not only what strategies might be useful, but what's actually going to be like translated into their everyday life. So this is where, you really have to understand what the mental manipulation demands of someone's daily life are going to look like. And then are they open to using strategies? Not everyone feels comfortable using a tool. So you have to make it accessible and practical for them.
Yeah. And it sounds like just based on severity level, kind of like you started the conversation, if it's someone who has more severe deficits, like that's when you could really do more of the external supports to help them function. But like more mild cases, you could do like internal strategies. So lots of options based on really the individual presentation.
Yes. And I also look at, really looking at the role of family. So we'll talk about that later. Really understanding that, working memory has to be managed somehow. And the question is, as with most rehab situations, can we slowly start to increase independence, right? Or decrease the role responsible for the family as things go ahead and change. So most of my clients that I'm working with are in the community. And they are fairly sort of independent and responsible for their strategy use. So strategies might look like breaking bigger pieces of information into smaller ones. That's, talk about that 6-digit 2-factor authentication. When I glance at that, I break it into 2 chunks. I might say it out loud, which helps take that visual information and put it into my phonological loop, right? So I'm able to really amplify the longevity, hopefully, of that information, as always making it personally relevant. I think looking at different ways like of mentally holding information that are very much sort of socially acceptable in conversation. So sometimes for someone who's losing track of what they want to say, they want to bring up, let's say, 2 points in a conversation while they're listening to their partner. I might have them, hold up their fingers on a hand. Put them subtly, on their lap, but it's a way of sort of saying, I have 2 ideas here and I can sort of fix them by holding onto them in my fingers, right? As always, we want something that feels like they could use it in everyday life.
Right.
And then really looking at reducing multitasking, because it is those task switching moments when we're just likely to lose information. The quality of that information can be sort of deteriorated. So I think that's a big piece of it. Again, working memory is not infinite. So for this little tiny space that you have, what needs to go in there? And so I think when people they assume that they can do it all, of course. And so really helping them to understand their brain does best when we can really allow that working memory to do its job without overloading it. Yeah. And then I really like to train mindfulness. I'm a big believer in doing sort of not just for emotional regulation, but really training people to learn how to attend to their environment. I think it's helpful for a variety of ways, but really looking at how we can put mindfulness into a task. So I have a client right now who's using a guided meditation app that's like 3 minutes long. He does that before an activity. And what it does is he finds that it sharpens his perception and attention.
No.
Again, with some nice effects on his working memory.
Yeah.
In my session, Sarah, I always focus on functional practice. So after we collaborate and we come up with this, we try to train the technique in an errorless way. And I really want my client to lead me on the impact of those tested strategies outside of our sessions. So it's really about, identifying the need, finding a strategy that feels like it's doable, figuring out a plan to use it, and then having them come back to me with feedback. And we really do look at ways to offload the cognitive demand. So some of that is like reducing the multitasking, but cognitive offloading, I think, is a term that we should define here. And that's the use of a physical action to alter information processing requirements of a task so we can reduce the demand. And that's building that metacognitive awareness, right? And training someone to really think about their working memory and, towards that goal of being able to execute a task without having too much other stuff kind of getting in the way or losing that information. So figuring out what helps you and then how can we put it into everyday life? Is rehearsal helpful? Are keywords helpful? Can we delegate to somebody else? Offloading is, I think, important, and it provides an opportunity to be more successful. So if I give them permission to cognitively offload, to manage maybe doing something at a different time or give a task to somebody else, and they see that they're more successful with holding on to information long enough to manipulate it, it reinforces that, right? And they have my permission to do only one thing at one time because it really optimizes their success. And it's all about showing success.
I also like how you're framing this for the SLPs listening, that you're really trying different strategies. It's not like you immediately are like, this person is going to use this strategy. That is the therapeutic process. And that's how you're spending your time, is like, hey, let's try this. Let's reflect. Okay, maybe let's try this one now. Like, which one do we think is going to work for this need that you have? And I think that's giving SLPs permission. Like, we don't immediately have to know. That is the therapeutic process, is discovering for each client and their need what's going to help support working memory. So thank you. I like how you kind of shared that.
Yeah.
Okay, so we are going to go to thinking about talking about maximum impact for our discussion. Can you tell us 3 actionable takeaways that clinicians should put into practice?
Yeah. So the first one we sort of have covered. I really want you to learn to notice when working memory impairments are happening, so that you can help your clients see the contextual demands and what factors can be helping or hindering their working memory performance. So that's especially as you are learning to observe, you want your clients to also learn how to observe where is it working memory versus attention or, some other domain. So some of it's really just getting to be a really good observer. The second thing I would say is giving clients tangible tools. One of the things that we've been doing a lot in my therapy sessions are using voice assistive technology, like voice commands on their phone, to help retain a thought or an idea that pops up. So what this does is this allows them to verbalize the thought, create an external note in case they need that in an accessible place, but then also avoid the inevitable visual distractions of looking at their phone, right? So this is for that person who complains, oh, I have an idea just popped into my head and then it's gone, right? So the idea is to say, okay, it's in your head. How can we turn it into, again, the phonological loop? How can I say it so I can hear it, but then use my technology to store it? And sometimes just verbalizing that can be super helpful, right? They just have said an idea out loud and it just sticks around a little bit longer.
So is this just like using the Notes app and then just doing like a voice, like, hey, don't forget to buy, juice boxes next week, or, like something like that?
Yeah, I actually like the reminders app for this because you can say to your smartphone, whatever the wake up command is, hey, phone, remind me that I need to get something off the printer, right? So my client who is working, in one room and her printer's in another room, when she gets up, she just loses her working memory, just doesn't support her. So what she says before she gets up is she says, remind me that I'm going to get papers off the printer. It writes it down on her phone. She can then go and get the papers because she oftentimes just saying it out loud has helped her with that phonological storage. And then she has a process where she goes through her app, her reminders app, and she just deletes all the stuff that was very much temporary storage.
Yes. Okay. I love that.
Yeah.
Great. That's
So
awesome.
it does
Okay.
give that like external system, like writing something down. But what I really think is it amplifies the signal of that phonological loop. And it takes an idea, which is very much an internal thing, and it turns it, when you verbalize it out loud, you run it through your language system, right? And you can hear it. And I just think, again, it's almost like if I took that elevator and I just made a little more room so we could have some more information in there. So, and you know what? Everybody has their phones, right?
Right.
Sometimes the act of learning this new voice assist command, these voice commands, is a great therapeutic activity. But most importantly, it puts the right strategy in the right place,
Mm.
right?
Wow.
And so that probably gets to my third takeaway is offer meaningful ways, right, to exercise working memory in everyday life. So and I talk a lot about this with my clients. Like part of this is just knowing how to strategize and taking care of your brain health. So we talk a lot about, what are ways of those 6 pillars of brain health that we always hear about? How can we use, let's say, learning this new app or trying to organize, your time management and your schedule so you can focus on things like fitness and sleep. All of this that's why these complex demands are so relevant. So working memory strategies and those brain healthy activities, it's like just a big picture. It's your working memory for a greater purpose.
Mm. Wonderful. Okay, awesome advice. Let's go ahead and help the audience apply it by using a hypothetical scenario or a case study. Do you have one to share?
I do. I
Yeah.
do. So I'm gonna actually go ahead and I'm going to think about that person who actually was, maybe using those voice commands. So let's say it's a female. She's in her 70s and she has a diagnosis of mild cognitive impairment. This is a very frustrating condition, right? So she's losing track of a lot of things. Again, just the diagnosis itself, it's not having major impacts on ADLs and things like that, but it's really frustrating and it's very discouraging. So this is the client who's getting up and she's losing track of what she's doing midway. She's trying to find a phone number to schedule an appointment. And by the time she gets into her calendar, she forgot the number. So it's a lot of that inefficiency. It's a lot of that frustration. So functional practice for her really talked a lot about understanding the nature of her diagnosis of mild cognitive impairment and a good amount of review of executive function strategies, especially related to memory and working memory. So that would be like organization, and planning to simplify the placement of her phone, her computer, her calendar, so that she's minimizing the amount of time she's spending trying to mentally manipulate information. We work on encoding strategies. So that WRAP strategy, the WRAP, write it down, repeat it, associate it, and picture it. I love that one. And we targeted use of her phone as a means to store information that she needs to remember. This woman is, meeting new people, and those are names and details that are very easily gone. So what she's doing is she's really like building out contacts in the phones where she might include not just, let's say, the name of a doctor, but, the address, a description of the doctor, a photo of them if possible. Meeting new friends, same thing. She's using the notes feature in her phone under the contact to really help her store very vivid visual information. We talked about those voice commands, where she's able to just say something out loud. We talk about those as like popcorn thoughts. They just pop up, so that she can really hold on to them. And then we really talked about practicing almost like, I would say like an inhibition strategy. So really following this one task in one sitting. So trying to really help her to understand she can't get up from her chair unless she's seen this task to its true end, because when she's getting up and moving around, that's where just details are falling out. And suddenly she feels like she's kind of just wandering around, not really succeeding at anything. And then we use role play to build in time pressure. I think this is important. Time pressure can really have an impact on working memory tasks, right?
Yeah.
So scheduling the appointment, if she's standing at the receptionist desk and they're giving her information, she's feeling rushed. And so she can't really use her working memory strategies. So a lot of it is trying to rehearse something before she's done it, repeating back information that is verbally relayed to her, scheduling it immediately, knowing how to use phrases to buy time. I think that's a big one that I use with folks are these sort of like active listening skills, which if anyone's ever heard me talk, they know I love those. It's really about helping people to get socially acceptable phrases that allow them to repeat information back. So, hey, Sarah, it sounds like we've been talking about, working memory today. Did I get that right? So they have a chance to take something they've heard, run it through their language system, and just confirm with that individual. It's super socially acceptable, right? It's not some weird strategy. It really is effective, and it helps people feel more confident. And if you're more confident, you're going to do better in that task.
I don't know that we always have done a great job of doing that in speech therapy because we naturally, as SLPs, we often give information in such a controlled way, right? Like we're like, oh, I'm going to practice, giving you a message, and then you're like, pause and let them process it. So doing more of that role play or, pulling in other people who might not use those same strategies is a great way to really bridge from, what you're doing to real life. That's awesome.
And the role play is a great place to problem solve. So if we try something out and they forget how to do the voice command, we can say, okay, not a problem. Let's really work on that, right? I will also use teach back, which is that strategy of, just so I know I explain this in a way you can understand, can you tell me back what I just said? And that's a real working memory task too. Yeah. So that's another way when you could build that into every therapy session. Hey, person, I just taught you about swallowing strategies. Just so I know I explained it, can you tell me what you understand? And that's a bit of their mental manipulation, unless you've been really writing everything down and, again, structuring it for them. Or I can think of lots of times when I was bedside with a patient and a doctor or nurse would walk in and, say something really quickly. And, they might interrupt my session. And instead of being really, sort of, distraught about that, I'll say, oh, hey, that was interesting. Tell me what you heard. Right. And suddenly they have to decide that information is in their minds. Are they able to, in their working memory, produce it for you? And if they can't, we might say, oh, you know what? I think he was talking about that medication. Let's see if we can find a way to store this information. Mm-hmm. So you give them that opportunity for functional practice. I mean, once you can start to see it, working memory practice is everywhere.
It's popping up all the time.
All the time.
This was such a wonderful discussion, Lauren. I love your plethora of examples, the way you inspire us to take this kind of like traditionally stale task or impairment area and really think about how it matters for our clients' lives. So to wrap things up today, what final words of wisdom or inspiration would you like to leave with the audience?
I think, like we had said, it's totally okay to be experimental. You do not need to have all the answers. In fact, the client really is the one who should be leading this in terms of sharing, their life values, their goals, what deficits they're navigating. And you really want to empower them to take some strategies for test drive and say, not everything is going to work. We want one thing that's really going to help you. So, for example, if we're thinking about the phone, right? How many clients have this brand new fancy phone their families got for them, and they have a terrible amount of difficulty with, troubleshooting a high-tech option. So we might play around with that, but we might say, you know what? Maybe you're kind of more of a low-tech strategy person, like maybe having an index card with some keywords that you can, rehearse before you go down and, ask someone a question. So really playing around with it. That's the fun part, and that is the therapy. And then I will also say it's really important to normalize the use of working memory compensations. So many of us, myself included, rely on memory supports to get the job done every day. And a lot of my clients now with new diagnoses and memory impairments, they are wistful. They'll talk about their perfect memories that they had before their brain injury, and they get really stuck in the negative perceptions of having a memory impairment. And there's a lot of comparison of what was before and what is now. And so I always really work on validating that loss always, but then helping them to focus on cognitive strength. So a lot of these executive functions they can use, and guide them away from fixating on, what's not working to what is helping them to be at their best. So I think those are the things that are most important in our roles as speech pathologists.
You have given us so much to think about and keep the person-centered care train rolling. It was really lovely to chat with you today. Thank you again, Lauren Schwabish, for the insight and clinical takeaways related to meaningful treatment of working memory challenges.
And thank you, Sarah. I love this podcast. It was a privilege to be a part of it.
Thank you for tuning in to this episode of Speech Scope by MedBridge. Please be sure to subscribe and listen to more of our episodes on Spotify or on your favorite podcast platform and at medbridge.com. If you're listening outside of the MedBridge catalog and would like to access the bonus resources and receive continuing education credit, simply log into your MedBridge account and search for this episode to find the accreditation details. Speech Scope also listens to you. If there's a particular clinician that you'd like to hear from, or if you have a clinical question or challenge that you'd like to see addressed on this podcast, please let us know by leaving a comment on our Instagram posts or by emailing podcasts@medbridge.com.